Hello everyone. Today we are going to talk regarding myocardial infarction. This myocardial infarction is an essay question for our university examination, and in this slide I have made points from Mandapa, the Manipal Manual for Medicine. So let's start. In this topic I am just discussing about what is the Marty's myocardial infarction, just definition part, then what are different types, clinical features, and different modalities for investigation and management, and post MI drugs also. So these just to write a 10 mark question. In the 10 mark question they will be asking about what is myocardial infarction, etiology they can ask, clinical features are main important things, and then investigation and treatment. So this is the important stuffs in the myocardial infarction. So let's start. What is myocardial infarction? It is irreversible necrosis of heart muscles secondary to prolonged ischemia. From the name only we can understand myocardial infarction. So ischemia is present. There is irreversible necrosis of heart muscles secondary to the prolonged ischemia. It usually results from imbalance in the oxygen supply and demand. Irreversible necrosis of the heart muscle secondary to the prolonged ischemia, and it usually results from imbalance in oxygen supply and demand, and most often caused by plaque rupture with thrombus formation in the coronary vessels, result in an acute reduction in the blood supply. Most often caused by plaque rupture with a thrombus formation in a coronary vessel, result in an acute reduction of blood supply. So definition part we just learned. It is an irreversible necrosis of heart muscle secondary to prolonged ischemia, usually result from imbalance in the oxygen demand and supply. That's it. Now let's see what are the different types. There are two different types according to the ECG changes and biochemical markers. There are two different types. One is non-ST segment elevation MI and one is ST segment elevation MI. From the name itself we can understand what are these. In non-ST segment elevation MI, there are only biochemical markers present and there won't be any ST segment elevation in ECG. In ST segment elevation MI, there will be positive biochemical markers along with there will be ST segment elevation in ECG. So you understood. Two types, non-ST segment elevation MI and ST segment elevation MI. Now coming to the etiology. As we all know, atherosclerosis is the disease that is responsible for most of the acute coronary symptoms including the myocardial infarction. Atherosclerosis. And not only atherosclerosis, that is the most common, but there are some other non-atherosclerotic causes are also there. They are coronary occlusion secondary to vasculitis. Coronary occlusion that is secondary to the vasculitis, hypertrophic obstructive cardiomyopathy, coronary artery emboli, congenital coronary anomalies, any coronary trauma. You can talk about different coronary conditions, that is any coronary occlusion that will be causing ischemia. So that is secondary to the vasculitis. Any hypertrophic obstructive cardiomyopathy, any coronary artery emboli, that also will hamper the blood supply. Any congenital coronary anomalies, that also will hamper the blood supply and it will lead to the ischemia of the heart muscles. Coronary trauma, the same. So these are the etiology. While asking about etiology, you can explain regarding this. Atherosclerosis you can explain. Along with that, these non-atherosclerotic causes also you have to explain. Now, in the etiology itself, we can discuss the pathogenesis. What's happening? What's really happening in this condition? There is rupture of atherosclerotic plaque. First, there will be rupture of the atherosclerotic plaque, and that will induce local thrombus formation. And this local thrombus will be occluding the coronary artery, and there will be myocardial infarction. So this is the flow chart. First, normally first we told it is most commonly seen in atherosclerosis conditions. There will be rupture of this atherosclerotic plaque, and then there will be a local thrombus formation, and that will occlude the coronary artery, and there will be myocardial infarction. So that is the thing that you have to write in the etiology part. And initially this subendocardium is affected because this is the least supplied area. First we told there is a blockage in the coronary artery, the blood supply is hampered, and initially the subendocardium will be affected because this is the least supplied area. And then subepicardial myocardium, and there will be Q wave, like transmural Q wave we can see in the ECGs and all. So that is the etiopathogenesis of myocardial infarction. I guess you guys understood. Now let's move on to clinical features. And mostly some precipitating factor will be present before myocardial infarction, such as any vigorous exercises, physical exercises, emotional stress, medical or surgical illnesses, etc. Because after these precipitating factors only MI will take place. And the most important clinical feature is chest pain. And the features of chest pain is very, very important. How the chest pain looks like, that is substernal and it is radiating to the neck, left shoulder and left arm. The chest pain is substernal which is radiating to the neck, left shoulder and left arm. And the chest pain in MI is severe than angina and it is last for more than 20 minutes. These points you have to write. Chest pain which is substernal, radiates to the neck, left shoulder and left arm. Chest pain in MI is severe than angina and it is last for more than 20 minutes. And also the patients may also have dizziness, syncope, dyspnea and fatigue. The main thing is chest pain. Along with that, the patient will also have dizziness, syncope, dyspnea and fatigue. And also examination will reveal diaphoresis. What is diaphoresis? That is excessive sweating. The patient will be having diaphoresis, pale, cool skin, tachycardia, a third or fourth heart sound, any bilateral basal crepitation, not reputation, it is crepitations, and sometimes hypotension. So now we learned about the clinical features. Just if you are telling the clinical features, you can explain about chest pain. Chest pain, that is substernal, you can say, and then it is radiating to the neck, then left shoulder, left arm. Chest pain is more severe than angina and it will last for more than 20 minutes. Along with this chest pain, they will be having dizziness, syncope, dyspnea and fatigue. And during examination, we can see diaphoresis, that is excessive sweating, pale, cool skin, tachycardia. There can be third and fourth sound present, and bilateral basal crepitations, and sometimes hypotension also. That's it. Now coming to the investigation part. First and most basic investigation that we are doing in myocardial infarction is ECG. Initially, the ECG may be normal, so we have to repeat the ECG every 15 minutes. And ECG will show ST segment elevation. Here I am talking about the second variant, that is two types we have told, ST segment elevation MI and non-ST segment elevation. Here I am discussing about ST segment elevation MI. So in ECG, initially ECG may be normal and we have to repeat the ECG every 15 minutes and ECG will show ST segment elevation. And the presence of new ST segment elevation greater than 2 mm in chest lead and greater than 1 mm in other leads suggesting of myocardial infarction. ST elevation greater than 2 mm in chest lead or greater than 1 mm in other leads, that is corresponding to myocardial infarction. That you have to keep in mind. Here there is a picture I have taken from Mandappa. Here it is given, left side you can see the normal ST segment and right side you can see the elevated ST segment elevation. Clearly you can see. Coming to the next investigation, that is biochemical markers. The main three important biochemical markers that will be elevated in myocardial infarction are CKMB, creatinine kinase MB, troponin I, troponin T. IT you can remember it as CKMB, troponin I and troponin T. Here troponin I and troponin T are very important as compared to CKMB, because CKMB can be raised in other conditions like any skeletal muscle injury and all. In those conditions also CKMB can be elevated. So three biochemical markers, CKMB, troponin I and troponin T. And nowadays newer modalities are also coming. What are the newer biochemical markers? They are myeloperoxidase, glutathione peroxidase 1, etc. etc. So biochemical markers is easy done. What is the third modality? Third modality is echocardiogram. Hypokinesia or echinacea of ventricular wall may be present due to ischemia or infarction. Ventricular wall, echinacea, hypokinesia may be there. So how echocardiogram is helping us? It can assess left ventricular function. And also, it can identify any presence of right ventricular infarction. It can assess the left ventricular function and also any infarct is present in the right ventricular or not. And any ventricular aneurysm is there, any pericardial effusion or left ventricular thrombus. These things, this echocardiogram can assess. Next one is coronary angiography. What is the use of this coronary angiography? It can identify site of block and allow percutaneous coronary intervention. Through coronary angiography, we can identify the site of block. Where is the block exactly? And it will allow us to do the percutaneous coronary intervention. So that's it. And the next one is radionuclide imaging. What is this radionuclide imaging? It is imaging with thallium-201 and technetium-99m sestamib scan. And these scans will be showing uptake defects. That means cold spots we can see. Wherever the infarction is present, there we can see it as cold spots. And it cannot differentiate between the old and new infarct. That is the only drawback in this condition. Radionuclide imaging. There are different other investigations also that we will be doing for most of the conditions, that is full blood count, RFT, serum electrolyte, glucose, lipid profile. So these are the other investigations. So once again I will just repeat the investigation part. The first and basic investigation that we will be doing is ECG. ECG points I have already discussed. Here you can see right side ST segment elevation. Biochemical markers also, see KNB, troponin I and troponin T. Troponin I and troponin T is more important. And echocardiogram, you can see it will assess the ventricular function. Basically ventricular function it is assessing. And then coronary angiography, site of block we can assess, and we can also allow us to do the percutaneous coronary intervention. Radionuclide imaging, you have to write thallium-201 and technetium-99M sestamib scan. This technetium-99M sestamib scan we have discussed in various portions also, like in surgery modules and all. And also the only drawback in radionuclide imaging is it cannot differentiate between the old and new infarct, because it is only showing as cold spots. Other investigations will include full blood count, RFT, serum electrolyte, glucose, lipid profile, etc. Now coming to the management, this is the most important part in the myocardial infarction. What are these management? The management part we can divide into different stages. One is immediate measure. The immediate measure is oxygen. Oxygen we have to give by nasal prongs or face mask. How much quantity? Like 2 to 4 liter per minute for 6 to 12 hours after the infarction. Oxygen should be given using nasal prongs or face mask 2 to 4 liter per minute for 6 to 12 hours after infarction. The second one is aspirin 300 mg plus clopidogrel 300 mg. Both are 300 mg. Aspirin and clopidogrel. Oral loading dose, and again it is continued with lower doses. So first oxygen we gave, then aspirin 300 mg plus clopidogrel same 300 mg oral loading dose, and then it is continued in lower doses. Then sublingual glyceryl trinitrate, 0.4 mg, and it should be repeated at 5-minute interval up to 3 doses. So main 3 important thing: oxygen, aspirin and clopidogrel, sublingual glyceryl trinitrate 0.4 mg. Repeat every 5 minutes up to 3 doses. Then IV heparin. Intravenous heparin we should give for all patients until and unless there is no any contraindications. If there are any contraindications, you should not give the heparin. And then morphine 2 to 5 mg IV. It will improve the chest pain and it will also control the anxiety in the patients. Then beta blocker, IV beta blocker, and metoprolol is the most commonly used, 5 mg every 5 minutes for 3 doses. The same thing that is used as the sublingual trinitrate glyceride. Sublingual glyceryl trinitrate also we are using the same for in 5-minute interval up to 3 doses. The same we are using for beta blocker also, that is metoprolol 5 mg. And there are some contraindications for using beta blocker. What are they? If the PR interval is greater than 0.24 second, or if there is any second or third degree AV block, or if the heart rate is less than 60 beats per minute, or if the systolic blood pressure is less than 90 mmHg, or if there is any previous history of asthma or COPD, we should not use beta blocker because that will complicate the situation. So these are the immediate drugs that we are using. Once again I will tell: oxygen, nasal prongs or face mask 2 to 4 liter per minute, 6 to 12 hours. Aspirin or clopidogrel, aspirin and clopidogrel, and sublingual glyceryl trinitrate, and then IV heparin, morphine, beta blocker, metoprolol is preferred, and then that is the immediate measures. Then coming to the reperfusion therapy. After the immediate measures, we have to go for the reperfusion therapy. There are 2 choices for us. One is percutaneous coronary intervention. The second one is thrombolytic therapy. The best and ideal method is percutaneous coronary intervention, but that won't be available in every hospital or every setup because it requires higher skills and good equipment. So that won't be available at every places. So it is depending upon the availability and the situation. First, let's talk about percutaneous coronary intervention. It includes angioplasty and or stenting, because sometimes angioplasty alone is done, or sometimes angioplasty is done along with stenting. If percutaneous coronary intervention is done without preceding fibrinolysis, it is referred to as primary percutaneous coronary intervention. In some cases, fibrinolysis is done prior, and then if no improvement is doing, then only will be going for percutaneous coronary intervention. And if percutaneous coronary intervention is done prior, then it is called primary percutaneous intervention. Where are these percutaneous coronary interventions are useful. It is useful for patients who have contraindications for any fibrolytic therapy, where the diagnosis is in doubt, any carcinogenic shock is present, or if there is an increasing bleeding risk, etc. In these conditions, we will be going for primary PCA only. Now let's see the second condition, that is fibrinolysis. What are the indications? The people with acute ST segment elevation presenting within 12 hours of onset, if primary PCA cannot be done, delivered within 2 hours of onset of symptoms. What are the indication? Acute ST segment elevation MI presenting within 12 hours of onset. And if primary PCI cannot be delivered within 2 hours of onset of symptoms, then we'll be going for fibrinolysis. And best if it is done within 1 to 3 hours after the onset of symptoms, and it can be done up to 12 hours also. There are trials that have shown very good prognosis if it is done up to 12 hours. So fibrinolysis indication presenting within 12 hours, and if the primary PCA cannot be done within 2 hours. Then coming to the fibrinolysis drugs and dosages. There are mainly 3 important drugs that you have to keep in mind. One is streptokinase. What is the dosage? 1.5 million units IV over 1 hour. Streptokinase 1.5 million units as IV infusion over 1 hour. Then tissue plasminogen activator TPA as 15 milligram bolus. It is not bonus, it is bolus IV, and then 0.75 milligram per kg over next 30 minutes, and then 0.5 milligram per kg over next 60 minutes. Tissue plasminogen activator 50 mg bolus you have to give IV, and then 0.75 over 30 minutes per kg, and then 0.5 milligram per kg over next 60 minutes. And it is ideal to give TPA plus heparin, because according to different trials it is showing if you are giving tissue plasminogen activator plus heparin, that is giving more benefit or more effect than giving streptokinase alone. So that is thrombolytic therapy. The next method is coronary artery bypass graft. It is indicated in patients with left mainstem or triple vessel disease, left mainstem disease or triple vessel disease with impaired left ventricular function. If that is so much severe, we have to go for coronary artery bypass graft. And then the last, not the least, but it's very important, the post-MI drugs. After the MI gets resolved, there are some drugs that we give to the patients for lifelong. What are they? Aspirin and clopidogrel, that we'll give for lifelong. 75 to 150 milligram per day. Aspirin, clopidogrel 75 milligram per day. You can both remember it as 75, that's enough. 75 to 150 aspirin, 75 milligram clopidogrel. Then beta blocker. As we said in the immediate measures of the beta blocker, metoprolol, carvedilol, atenolol we will give. And then oral nitrate, isosorbate dinitrate or mononitrate we can give. Then ACE inhibitor, enalapril, ramipril, etc. Then statins, atorvastatin, to reduce the LDL. And LDL we have to keep it below 100 level. And calcium channel blockers, and we have to control any comorbid conditions if it is there, like any diabetes, hypertension, etc. And we have to tell the patient to stop smoking, because these all will again make him prone to atherosclerosis, clot formation, and then ischemia and myocardial infarction will be there. So these are the post-MI drugs: aspirin, clopidogrel, any beta blocker, oral nitrate, ACE inhibitor, statins, calcium channel blocker, and we have to control the comorbid conditions like diabetes and hypertension, and then we have to tell the patient to stop smoking. That's it. So these are this is not everything, I know, but minimum these things that you have to write if it is asked for a 10 marker. You have to keep different headings, and you have to explain everything in a good way, like with flowcharts and all. So that's it. Thank you all. Thank you for your time.